Okay, everyone, welcome to Grand Rounds. And I have the pleasure of introducing an old colleague and friend, Dr. Michael Thomas. He is a professor of obstetrics and gynecology and chair of obstetrics and gynecology at University of Cincinnati. And I realized I was looking at his CV. I've known you, Dr. Thomas, for 32 years.
Yes. A little bit.
Yes. He was, in fact, I asked him to present because I read a very interesting article that he wrote in Fertility and Sterility last year about mentorship. And I realized, didn't think we had ever had a Grand Rounds that was on mentorship per se. And I thought this would be an interesting topic. He was born in Illinois and got his bachelor's at Northwestern University in radio, TV, and film. He has a lot of interesting stories to tell about that.
Yeah.
He received his MD from University of Illinois, did his residency at Wayne State in Detroit, and his fellowship at University of Cincinnati. And I met him there when I started as a fellow. He had just finished. So he was one of the people who trained me. He currently, he's done quite a bit of research, both federally funded and industry funded, on contraception. And that's where most of his publications are. So I'm proud to introduce you, Dr. Thomas, and won't take any more of your time. Thank you.
Thank you very much. I appreciate the introduction and appreciate being invited for Grand Rounds here. You're right. I was a radio, TV, film major at Northwestern. Went to school with a woman that, believe it or not, some people don't know. Her name is Julia Louis-Dreyfus. She did a couple of TV shows, and she's done pretty well for herself, and a couple of other people. We were a pretty, hopefully a close-knit group back then. But I had a television studio. We had a television studio at my high school, so that's what spurred my interest. So I was one of the few. There were actually two of us pre-med radio, TV, film majors at Northwestern. So my talk today is going to be on primarily concentrating on our DEI task force initiatives in American Society for Reproductive Medicine. And I've been affiliated with ASRM since I was a fellow back in the late 80s. I'm currently the president-elect of ASRM as of October. And this coming off as the REI division director of ABOG, American Board of OBGYN. I've done that for the last 3 years, but have been on the REI division of ABOG for 7 years now. And I'm rotating off. So if you get any MOC articles or some bad oral exam questions, you can't blame me anymore. I am happy to give up the MOC. MOC seems to come up weekly on my end when you're writing questions related to the articles that people need. But I will admit, being on the American board has been one of the best experiences I've ever had as far as education, particularly when it comes to the examination process and all of that stuff. And I would we've even had a couple of lectures from some of the ABOG people who come in and talk about the psychometrics, how they put exams together. That's a very fascinating scientific aspect of test taking. So one of the reasons that we sort of wanted to look at, and we'll get into mentorship a little bit, but when ASRM decided to put together a diversity, equity, and inclusion task force, it was put together based on a number of different things. One is what's gone on from a patient standpoint. And in a state like Massachusetts, where you have an IVF mandate, it's a little different in states where they don't have that mandate, because not all people get coverage. And even in mandated states, unfortunately, people of color who work in possible jobs where they don't have enough employees where the mandate would take effect, they also are somewhat discriminated against and don't have the IVF coverage. But one of the problems that we have is that women of color avoid seeking fertility coverage, not just necessarily because of insurance-related issues, but when we talk about women of color, we're talking about women who are African American, Hispanic American, Asian American, and Middle Eastern heritage. Sometimes there may be some communication differences when it comes to seeking fertility care, and you may not have someone on the other side who speaks your language or has the ability, unfortunately, to get an interpreter. So that may be one of the reasons where people don't go to the next step after they see their general OBGYN. And there is some cultural stigma associated with having a fertility problem. There may be some aversion to being labeled infertile in some communities. And there is also in some communities an emphasis on privacy. They don't really want other people to know that they have fertility issues. And it may be a stigma, especially for the woman. And we see that a lot in some of our Middle Eastern populations and African populations, where a woman who has a fertility issue may be not necessarily accepted as readily into that community. Some people have had bad experiences with the medical community. Unfortunately, our people of color may have had experiences where they were not treated as well by providers. And then when they are being sent to a specialist, that bad experience may carry over. And of course, there may be the economic barriers for those who don't have coverage. Like I said, there are some mandated states like Massachusetts, but it's not mandated for everyone necessarily. So some of those economic barriers affect everyone, but more so women of color for the reasons that we discussed. There are 19 states that have some degree of fertility coverage, with only about 14, with one or two just coming on board that have IVF coverage as well. And there's a mandate to get more IVF coverage across the board. ASRM, of course, Resolve, which is a patient advocacy group working with ASRM, as well as other advocacy groups, to try to overcome the lack of IVF coverage, or even the lack of IVF coverage in job sites. And that's another thing that comes up in order to maintain our nursing staff. One of the things that some hospitals are doing, besides trying to, and we've learned this since COVID, besides trying to give big bonuses to people, some hospital systems are anteing up IVF coverage as a way to keep their folks in the medical community, who generally, particularly are women, and particularly between the ages of like 20 and 40, who may want to have this coverage for a number of different reasons, whether it's to freeze eggs or at least to have IVF coverage or fertility coverage in general. Some economic barriers also come up because some people of color may have been denied access to more effective care, meaning that they may have some coverage for, say, Clomid cycles, but nothing beyond that. Other economic barriers is the fact that you have to take time off work if you're going through cycles. The fact that, to do an IVF cycle, you have to be off for an hour or two to get an ultrasound, and then to be off for a day or two after an IVF retrieval may be an economic barrier for some people. And also frequent travel for people who are in rural areas or in areas where there's not a lot of IVF coverage. We're lucky in Massachusetts, especially around the Boston area, to have 8 million IVF centers. But there's some certain towns like Boston, New York, Chicago, Los Angeles, where there are probably just as many IVF locations as there are McDonald's or Wendy's. But that's not the case if you get to places like Cincinnati. There aren't as many IVF centers as there are in the bigger cities. So the geographically distant folks may not have as much of a ability to get in to see a doc. And if you're living in a big city, an IVF center may mean that you may have to take a couple of buses or an Uber to get to those sites in order to get coverage. And also the economic barrier associated with repeat cycles. As much as we would love to have 100% IVF cycles as far as pregnancy rates are concerned, that's not the case. So at most, we're talking about 50 to 60%, and that doesn't always translate, obviously, in getting pregnant the first time. And then there's the high cost of gestational carriers for our male same-sex couples or single males or people who choose not to use their own uterus for pregnancy. Therefore, the cost for those folks has to be factored in, which could be anywhere from $75,000 to $100,000 plus. Women of color encounter conscious and unconscious assumptions about their fertility. There are a number of studies that have shown that women of color are just thought to be fertile. They see a lot of people on television and they see other people who get pregnant, but they don't understand that just because you are Black or Hispanic or Asian doesn't mean that you are automatically a person who can get pregnant, and you just need more time, and that more time can't translate into 5 years and 10 years where people are continuing to try and then being pushed off, and now they're past the age that they can potentially get pregnant. And this is not an uncommon phenomenon where we have either our primary caretakers or people who are on, say, the front line of healthcare, whether they're the general OBGYNs and or our internal medicine or family medicine providers who actually may tell, and this has been shown in the literature, they may tell their African-American and Hispanic American patients to just keep trying, despite the fact they don't have regular cycles, despite the fact they may have a potential risk of tubal factor, despite the fact that their partner has been tested and they are now out there for 2 years, 3 years, 4 years. And these people of color tend to come back and tend to finally see a fertility specialist at a much older age when it is then more difficult to get pregnant. There's always the discussion of the use of birth control over procreation. So discouraging people of color in getting pregnant versus encouraging them of getting pregnant, not telling them to just use birth control, but actually trying to get pregnant. And also there have been studies where people of color have been dissuaded from having children. Lower success rates are noted in our African-American, Asian, and Hispanic women in most IVF cycles. David Seifer at Yale has done a lot of this work where he's shown that even given the same age range and same weight, there are lower implantation rates, low clinical pregnancy rates, and an increased miscarriage in women of African-American descent, Asian descent, and Hispanic descent. The reasons are really poorly understood, and they haven't really been sufficiently studied. So those are areas of potential research that our task force wanted to take on. And of course, there are barriers to our same-sex couples and single women and single men. The definition currently for ASRM for infertility is 1 year of attempting conception under the age of 35 for 6 months if over the age of 35, which means you have to have exposure to sperm. And if you're in a same-sex relationship or if you're a single woman, you may not have that exposure to sperm. So your infertility insurance may not kick in until you've had 6 IUI cycles or X number of IUI cycles. And some insurance companies, even in mandated states, are very, in some ways, prejudiced against our same-sex couples and single women. But there's been more of a discussion to open that up. And I know in some insurance instances, they have opened that up when you have a same-sex couple. but there also may be some provider, religious, or personal beliefs and the struggle to be recognized as intended parents. There's no data on racial or ethnic backgrounds of a lot of our current board-certified reproductive endocrinologists. So the question is, how many people are actually practicing in the reproductive endocrinology field, both as providers, but also in the laboratory and in our nursing profession, and in our and for those who practice psychological support for our patients. And we need to also increase the number of providers of color because studies have shown that people of color are more likely to go to those folks and to also go to and stay in a practice with someone of color. We are now trying to gather that information through ASRM based on our task force work. But in one of the most recent surveys of the fellows in reproductive endocrinology, it was noted that 7% in December in 2018, 7% were African American, 3.2% Hispanic, 14% Asian, and 4% declared as multiracial. So with all this in mind, a task force was formed. I was appointed chair of the task force in April of 2020. I had taken the job of chair here in Cincinnati in March of 2020, a week before COVID really hit the you-know-what. And then a month later was asked to, on top of that, take on this other role to establish this task force. Obviously, the home institution, there was a lot going on with, as you can imagine, COVID-related issues, especially when we were trying to mobilize physicians and providers to work in units that they had not worked in before, whether it was an ICU unit, and actually I had actually brushed up on I made sure I had OB privileges, which I hadn't done since being a fellow in since the 1990s, a little bit after being a fellow, as Dr. Seitz can tell you, we were doing OB as fellows back then, but I hadn't done anything since the 90s, so I had to brush up on delivering babies. My wife, who's an OBGYN, kept telling me, hey, babies come out, you just don't stand in the way of it. But I was getting everything ready for that, but then I also took on this role as the leader of this task force. And our charges were, one, to enhance opportunities to increase and support diversity and equity and the inclusion of underrepresented minority populations in the profession and leadership of reproductive endocrinology. So the thought was, if you can increase the number of underrepresented minorities in REI, you would hopefully have patients come to those folks. But the fact that we didn't have any information on who was in the profession was a little bit problematic for us. And two, the second charge was, of course, patient-related, and it was to reduce and eventually eliminate health disparities in access and outcomes to reproductive care. So we sent out invitations to all ASRM members, and based on personal and professional experience and those who demonstrated a commitment to task force goals. And then once we got people in, we had about 11 people that were part of the entire scope of reproductive medicine, which included not only physicians and nurse practitioners, but also lab folks and psych folks. And we just wanted to be inclusive and diverse in all aspects of the profession so that we had a good understanding of what to do and how to put together our recommendations based on the scope of individuals. So our working group included, was divided into two. The one on professions was spearheaded and chaired by Gloria Richard Davis from the University of Arkansas. Gloria started our Health Disparities Special Interest Group at ASRM. And then and also in a group were Arthur Chang, PhD lab director at in Texas, Janetta Darno, who's our DEI officer here at University of Cincinnati, Kevin Thornton, who's Boston IVF, Ms. Middlebrook, who's an RN with Shady Grove in the Washington, D.C. area, Dr. Lansky, who's a psychologist, and Ruben Alvaro, who is a REI at Stanford. And in our Charge 2 group, which was a patient-directed group, we had a PhD nurse practitioner, Maureen Siebert Gators, then Tia Jackson Bay, who's in New York, Camille Hammond, who's not a REI physician or even an OBGYN. She's an internal medicine doc, who's the head of the CADE Foundation, a patient advocacy group. So we wanted a patient advocate involved as well. Mark Leondaris, who's in Connecticut, who heads our LGBTQ group within ASRM. Yannette Anyata, who's a resident, Dr. Plowden, who's in the military, and Jennifer Wood, who's a nurse in one of the practices within I think one of the other practices, I think in the Washington, D.C. area. So we all got together in the summer and fall of 2020, and we started to meet and talk about what we wanted to discuss and to put together recommendations based on the 2 charges that we were given. And for the first group, to enhance opportunities to increase diversity and equity, that was chaired by Dr. Davis, our recommendations was to, first of all, perform an environmental scan, which is what we're doing now, to try to figure out what the scope of the problem is, how many people of color or self-declared either of color or within the LGBTQ community, so we have a better idea within the profession. In order to enhance the profession, we need to have an idea of who's in the profession and how many people are there. We also decided to expand and focus on recruitment and retention of a diverse workforce, increase outreach, education opportunities for diverse populations, and expand and enhance training to support a diverse and informed workforce. So in order to do that, the environmental scan was to establish demographics, which ASRM is doing now. So when you renew your ASRM membership, you have the option, you don't have to, but you have the option of declaring your ethnicity, race, sexual orientation. And we're trying to figure out where people are as far as practice is concerned in academics, and to look at providers, psych service personnel, as well as laboratory personnel. And also working very actively to see where we are as far as our society leadership positions within ASRM, SREI, SART, and our other organizations that are under the ASRM umbrella. We wanted to we recommend and to expand the diversity of our fellowships and postdoctoral pool. We talked about the number of people from 2018, and after the George Floyd death, there does seem to be an increase in trying to get more people of color in our residency programs and our fellowship programs. But we also are doing, unfortunately, a poor job in trying to get postdoctoral students interested in laboratory as a potential aspect of their career. So that's something we really need to do, because there are very few people of color in the laboratory, and also trying to make sure that we go and develop our pipeline to increase nursing and psych numbers as far as people of color are concerned. And we want to start to develop and sustain mentoring programs. And you'll see this year at our ASRM meeting, we're going to do a couple of things. One is that we're going to increase the pipeline by reaching out to kids in the area that we're going to be in. So in the Southern California area, particularly Compton, we're going to bring kids in to participate in some of our lectures at ASRM. and we're going to have special sessions with STEM students in the area. We're going to do this not only in Anaheim this year, but also when I'm president the next year in New Orleans. We're going to actually have students from a lot of the STEM programs and the HBCUs, the historically Black colleges in that area, to come in and participate in our ASRM meeting. And we want to uphold this as a codified way of doing things as we move forward to try to increase that pipeline within our specialty. Our pipeline increase has to be strategic. It can't be accidental. And we also have to start earlier than college or medical school. So I recently in May went to my junior high or middle school, and we brought simulators, and we are trying to get 7th and 8th graders interested in what we do to show that anyone can do a hysteroscopic polypectomy, even a 7th grader. So we figured if we can start the pipeline early, the better off we're going to be in our profession as we hopefully get some of these kids interested at a very early age. So the second charge was a little bit more robust because we needed to look at the issues related to the health disparities as far as access to care and then outcomes are concerned. And we had different charges that we put in place related to trying to break down some of these the disparities associated with the profession. And as far as inclusive, we wanted to make sure that all of our language and all of the documents that we put out had inclusive terminology. So we wanted to change, making recommendations to change the definition of infertility so that our members of the LGBTQ plus community, single women, single men, and even people with disabilities are included. If you look at some of our definition and terminologies, which is picked up on by our insurance companies, we want to make sure that they were included in the terminologies that we have so that they could have coverage in those areas, in those states where coverage is allowed. Also, we wanted to try to do what we can to reduce infertility stigma. So we want to work with local and national support groups to look at the current areas and barriers related to stigma, whether it's related to race, ethnicity, or religious barriers that come up, and try to break those barriers down and try to come up with information that will help to break stigma of infertility so that people don't see it as a problem and are more open in their discussions and normalize the fact that infertility is a common issue amongst people that affects anywhere up to 20% of those who want to have a child. We want to support education in reproductive health, so educate providers in best practices, discuss future fertility concerns in the underrepresented minority population, which includes trying to have an earlier discussion with preventing STIs, because obviously STIs can increase the chance of a tubal factor infertility and also can cause potential infertility in men. Also, a more open discussion about anovulatory disease states and how they can affect their fertility in the future, women's fertility in the future. And obviously, the treatment of endometriosis and trying to treat it early and trying to get a handle on it so that it doesn't become a cause of fertility problem later on in life. As far as universal coverage, there is a push, as we said, to mandate fertility coverage in all 50 states, which would be inclusive of IVF and fertility preservation. So that for those who want to save their eggs for a future time, or for those who want to have IVF coverage now. Unfortunately, as we said, Massachusetts is one of a few states that have that. ASRM is working very hard to get mandated coverage throughout all 50 states. And of course, the problem then with that is that we don't have enough REI providers if all of the states went to mandatory coverage. So there are some companies that are working with general OBGYNs and teaching them to do retrievals and transfers because of the potential person power issues that we're going to have now and in the future. And there's also a push to increase the number of REI programs in order to meet some of this potential demand as more states become mandated. One of the other mandates was to encourage opportunities to provide low-cost services for those in those cases where they don't have coverage. And so we're trying to work with REI practices who will work with OBGYNs, family medicine providers, and internal medicine providers to help with first-line coverage to make sure that REI practices can work with their patients via telemedicine to do pre-screening, diagnostic visits, and to possibly enhance at-home testing so that people can get a basic idea of where their fertility stands. That at-home testing may include just basic semen analysis information and even AMH numbers to try to get an idea of ovarian reserve. Expanding inclusive policies. So ASRM is going to play a bigger role in consolidating advocacy efforts. Obviously, we talked about increased insurance mandates and coverage and trying to reduce economic and non-economic burdens and increase education through practices and having educational services to try to reduce disparities and trying to enhance the patient education aspects of what ASRM does so that patients can have a go-to place to understand what their fertility is and understand what fertility issues they may have questions about. Having transparency and reporting fertility results, so making sure that SART, and they've done some of this, includes racial information, sexual orientation information, so we can get that information about patients and also relationship status, and ensure that DEI is present and of importance in all of our ASRM publications and their sister journals. So if we're talking about a study that comes out that talks about fertility, how does that affect Hispanic women? How does that affect women of color in general? And one of the things we want to do is have people give a statement on their recruitment efforts because recruitment should obviously ideally mimic the recruitment of their community. And if it doesn't, we need to understand why it doesn't so that we can have a better understanding of that study and how it affects every patient. So in summary, there are factors that pose immense burdens for individuals of diverse backgrounds, which include, as we said, the high cost of treatment, inaccessibility for everyone to get medical care because of potential transportation issues, and infertility that could have been prevented. So making sure that patients are treated early for infections that may lead to tubal disease, and making sure that there are no delays in seeking care. Also, having a deeper dive on the differences in success rates, despite the fact that you would think everyone's the same. Most of the studies actually show that everything's not the same, and that even with the same age, even with the same weight, there are differences in success rates, as we discussed, in our African American, Hispanic, and Asian populations. And making sure that we overcome the lack of accessible education and try to reduce the implicit biases and discrimination that continue to exist. There's still some areas of the country where trained REIs don't want to see same-sex couples. There are some areas in the country where there are trained REIs who won't see biracial couples or couples of different race. So these types of things continue even in 2022. So as codified by our ASRM mission and values and ASRM values in general, prioritization has has been set forth, so that from an ASRM standpoint, diversity, equity, inclusion is of high priority. And the president, now Marcel Cedars, have made sure that these recommendations or statements are ongoing, and we're continuing to have discussions related to the next steps on how to put some of these actions into place. And a copy of this of our task force recommendations, I think you were all given, and a copies on the ASRM website. And the ASRM leadership and staff have made diversity, equity, inclusion a high priority based on these task force, the task force work that we've done. And with that, I wanted to save some time for questions.
Thanks, Dr. Thomas. I always enjoy talking to you, and congratulations on becoming the next president of ASRM. If you think you're busy now, I'm sure you'll be a lot busier.
Right.
So one of the things that, I've been interested in is the number of fellowship positions. And you mentioned that, it really does seem like there's an increased demand, at least here locally, and nationally that seems to be true. So I'm just wondering where ASRM and ABOG stand in terms of supporting increased numbers of fellows at the current fellowship programs, or creating new programs, and where the funding could potentially come from. Do you have any thoughts on that?
Yeah, I will tell you that ABOG, I could talk about ABOG first. ABOG doesn't control, ABOG only certifies fellows. They don't control the number of programs, but ABOG has been working very closely with ACGME and to talk about how to enhance that. ACGME doesn't understand the research part of things, and I will tell you that they have wanted the fellowships to sort of, I shouldn't say downplay research, but they feel in some ways that research isn't done in all fellowships across other specialties. So they're having a hard time understanding our research. I don't think they see it as a barrier necessarily, but the mandatory time for research has been reduced from a mandatory 18 months to now a mandatory 12 months. But you can use 6 more months for elective. And I think some of the REI program directors, fellowship directors, have been a little up in arms about that because they were thinking that research is not important. And that's not what ACGME is saying. But because all 90% of our fellows go into private practice, there is some discussion on what is research and how should it be used within the fellowships, and is that a barrier to getting more fellows out there? And I don't think it is. I do think we just need to potentially increase the number of fellows in the programs that are doing well. And unfortunately, the burden of that falls back on the programs, whether you can get your state monies that you use for GME to cover additional fellows. But most deans are already strapped with the number of residents that they have on different PGY years. But I think if we're up to ABOG and ACGME, I think there's an understanding that there is a need for more fellowships, but they have to be good fellowships. There have been some fellowships that are open and closed pretty quickly, which left a number of those fellows in the lurch that were in those programs. So trying to get good fellowships out there with good people like yourself running those fellowships would probably be the number one priority for ACGME and ABOG.
Thank you. Yeah, a big task. And some of it clearly is financial. And then, like you say, the quality has to be there.
Yeah. And there's been a discussion, does having a research mandate in fellowships, does it discriminate against smaller programs who don't have the ability to do research? But since in all of our OBGYN fellowships, research has, in some way, shape, or form, has been incorporated. The question just is, to what extent does research play a role in education of fellows?
And just to, sorry, if I can just, because I think that's a really interesting question. And because what we're hearing a lot from residents going through the amount of debt they're coming out of medical school and then residency and then 3 more years of fellowship. And as a generalist, I've often seen that sometimes what we need the most out in the, non-big cities, rural and suburban areas, is people that can actually perform IVF, do the clinical work. And I've always wondered why our field doesn't sort of have a 2-year clinical fellowship and a 3-year clinical plus research fellowship as sort of an option, depending on which route you want to take. And I think you'd get people to both, but I think expense is a big issue for a lot of people.
Yeah. I think the thought is that the fellowships, even if you go into private practice, give you a good understanding of what happens from in research, in the research area, in the laboratory especially. And the thought is that you have a higher level person doing your IVF cycle. But I think the question just is that what patients want or need? Is there a role, which some programs are going to have basically like a anesthesiologist, CRNA type thing within reproductive medicine, where you have a trained RE, but you have general OBGYNs actually doing the retrievals and transfers. And I think that as much as we feel in REI that there's this mystical aspect of things that we know more so than others, but I think that may change over the next couple of years. I hope that there's still a place, and we want to make sure there's a place for REs. But we'll see. And there's always, as there are more cycles being demanded, there aren't going to be enough REs to keep up with that demand. So something's going to have to change, and we'll have to come up with a different way of doing the work that we do today. Either to shorten the fellowships, to get more trained REs out there, or to bring in our partners, whether they are general OBGYNs or APPs, to do more and more of the work. And we're seeing more and more nurse practitioners and physician associates who are coming into the field to enhance what we do in our offices these days.
Well, that's a good point, because when you're talking about something procedural, it's a specific training for the procedure. It's not the one making the plan.
Right. And will that help to decrease costs? Because that's the other thing that we have to think about, is that, a lot, what people, if you have an insured patient in your office and if you had a non-insured, you want the non-insured patient, you're going to get more money from the non-insured patient. So the question is, if we get more and more insured patients and the costs are forced down, the question is, as a administrator, you want to make sure that you can cover the cost of an RE, possibly by hiring less REs and more people to assist the REs in their job.
Interesting thoughts. One thing I wanted to ask you too is about mentorship. You wrote that interesting article, and any ideas on, or have you seen good mentorship programs around the country or where you are? And could you make some comments on that?
I think that one of the things that we're trying to do with ASRM is try to get and develop a mentorship, especially in our residents and medical students of color. And we're going to try to have a proactive mentorship program starting this year at ASRM, where residents can actually not only get mentorship at their home institutions, and to try to at some point have some mentorship programs. Kim Thornton from Boston is sort of spearheading that effort in trying to get mentorship amongst the URM residents and fellows, and also putting together programs on negotiation, as most of you who are on this call have had to negotiate a salary or a car or something at some point. And to have that skill, I would tell you one of the best classes I ever took was in a leadership program over a year where learning how to negotiate was a big part of that. And that's when you go to your chair to negotiate an increase in your salary, or you go to your chair to negotiate your first salary, everyone has their way to do it. Sometimes it's just template, but sometimes there's a way to enhance things. And I think having those skills are important, and it's part of the mentorship of a individual. I know Dr. Seitz and I sort of had the same mentor. I had Dr. Rebar around more than she did. And I know you've worked with Dr. Rebar again when you were in Birmingham. But Bob and I have been around. I still call him for certain things when it comes to questions about things, and he's always been available. And, you have to have someone who is working for you when you're around, and obviously sometimes working for you when you're not around. I would tell you one of the things when I was a fellow that Dr. Rebar used to do is to take me to some of his chair meetings and just put on a white coat and sit in the back and just kind of observe. And he would always say, this is what you're going to be doing one day. And I was very lucky to be placed in those situations. Didn't understand it, why he was doing it, but now I do. And it's been very helpful to sort of see how the sausage is made in the background when you're the fellow, and learning how to some of the times just doing the opposite of what Dr. Rebar did back in those days. But just learning the machinations of how an administrative role would be that I've been very helpful for me in my time as chair here. Any other questions? And I think that, having formal mentorship training is very important. I know that at the University of Cincinnati, I've been involved in some initiatives to train mentors in each department who would then go on to train and mentor people in their departments. And we have a formal mentorship program here in our department. Matter of fact, myself and Dr. Elizabeth Kelly, who's my executive vice chair, she helps to, we are the mentors for all the interns who are coming in. And then after that year, everyone gets another mentor, particularly in their area of interest. And it's very important that they have someone that they can go to. And then over the years, you may add an additional mentor, not only from an academic standpoint, but sometimes from a career standpoint that may help you to open some doors. And that's what I always consider my role is as a mentor, is to help open doors for people. That's what I learned from the mentors that I've had, whether it was my former chair as a resident who still calls me up and gives me advice. I saw him at ACOG the other day, and he took me off to the side and told me he needed me to do this, 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 and this. Or Dr. Rebar, who calls me up not only with golf jokes, but also someone who who helps to steer what I'm doing, and has been also a very good person who's opened some doors for me. One of the stories I always like to tell is when I was on the ASRM patient education committee, and like 6 months later, I was all of a sudden the chair of the patient education committee because as part of the Cincinnati Mafia, I was told that this was the expectations that we were supposed to sort of take over ASRM one day. So doing that slowly but surely. Well, I thank you all very much, and I thank you for the opportunity for speaking today. And I appreciate everything. I appreciate being invited by both Dr. Seitz and Dr. Sankey. And thank you very much for the invitation.
Thank you.
Take care.
All right. Take care.